in my screen?
Good. Yes, we can. Thanks, Debbie.
Excellent. All right, thanks. So I'm going to kick us off with a bit about what Connect Care is, but then I'm going to launch into the nursing clinical content and how we are starting to think about the work that nurses do and the standards that we build in the system can look towards improving patient outcomes. So Connect Care is big. We just finished our 6th launch of Connect Care, but when we're done this project, it'll be in November of 2024, we would have brought on within AHS over 110,000 staff. We have reached partners, we've reached AHS, ambulatory and inpatient in our implementation, but we've also done the bookends of population and public health and seniors in continuing care. We are doing Covenant, we're doing physicians, nurse practitioners, students will be involved in Connect Care greatly. And some of our partners or subsidiaries, if you like, Care West, Capital Care, and Alberta Public Labs. So it's a big project. It's been spanning over the last 4 or 5 years for implementation, but prior to that, we did a lot of work around standards. I won't get into too much of the facilities, but we have primary care, we have acute and ambulatory, nursing or inpatient units, and then ambulatory clinics for all clinical specialties. And then we do the end where we're looking at seniors, palliative, end of life, community hospice. We're doing all of that. The scope itself, at the end, there will be very little paper left, if any, like little bits here and there. But for the most part, we are creating a full electronic health record with all of our practice areas. So if you think of clinical specialties, we'll have cardiology, medicine, surgery, addictions and mental health. We are looking at having an Indigenous program and looking at the well-being and how we have a lens and Connect Care from that perspective. We have over 28 different applications in the Epic system that we will be implementing. And then we have a lot of foundational tools and technologies around the Epic system. Epic will be our electronic health record, but we support that through integration of other technologies. So, Dragon Speech, for example, we have Teams integrated into Epic so that we can do meetings with patients and Zoom, that sort of stuff. So there's a lot that's bolted into our system on top of that. So pretty comprehensive. Our timeline, we started our first launch November 3rd in 2019, and we'll be finishing this in spring November of 2024. So that would be 5 years almost to the date. We had some postponements during this with COVID, but we were able to, move around that. COVID right in the middle of this has caused some blips, but we're a nimble project. When we start to think about clinical content, and this is where I first met Rob, and so we shared many years together doing clinical content and enabling that in our Epic system. So really looking for healthcare providers, the clinical content enables them to make the right decision at the right time and point of care. And what we like to do is there is discipline specific content, but more and more as we move to team care, we're seeing a lot of our clinical content being shared across, kind of have 4 domains here: orders and results, advanced decision supports. So those would be alerts and triggers to help you make good decisions, clinical documentation, and then clinical inquiry and evaluation is around the reporting. And so we're always thinking about how does that look across the domains of patients, physicians, nurses, and allied health? But then even how does that look across, I'm in an inpatient unit to an ambulatory clinic? Because you really want to think about your data out the back end before you start. You can look at clinical content from many perspectives. One was this perspective where we're thinking it across how providers provide care and share information, but also across domains. But then you can start to break it down and start to think about it from different perspectives, such as maybe what your health record comes with, or how you're going to look at your analytics out the back end. And so these are just some areas that we've talked about where we're starting to look at what is and where is clinical content. Like your person management is around your patient portals. And I'll get into a bit of that in through the presentation. Encounter management, med management, your med rec and your best possible med history, orders. Documentation is, nursing workflow is based on documentation. And so I'll go into a bit of that, more of that as I go through this presentation, because it's primarily around nursing. Absolutely need to be thinking about outcomes and how we're contributing to patient outcomes and better outcomes. And then you have your health system management. Some goals of our nursing, when we started all of this and started to think about how to enable nursing and electronic health records, was reducing the burden and eliminating duplication in our documentation. It's going to be a goal, I think, for a long time. Always need to be considering the evidence-informed best practice. So things that Lynn and Peggy might have talked about would be CHOBIC, what's going on in, nursing sensitive indicators and how you build that into your documentation. You always have to think about your professional and regulatory requirements, lots of opportunity to incorporate decision supports. We want to standardize the vocabulary across all care settings, right? So a blood pressure should be a blood pressure in inpatient as it is an outpatient. We want to standardize how we do our scale scores and tools, not only across nursing, but across all providers if possible. And we need core data sets for nursing. That was something we thought about. What is it that's enterprise that nursing does in the same way in medicine and in surgery and in addictions and mental health and in critical care, for example, because you can get those core data sets. And then it always needs to support the patient and the family, because that's a big part of AHS's mandate is patient and family-centered care. We had approach to standardization where we created a foundational governance. We looked at tracking our decisions. We looked at how we standardized our processes and how we scaled it up to bring it enterprise-wide, how we consulted and engaged, and we listened to our clinicians. And then we are now in this fourth stage where we're maturing the approach of moving into optimization. How do we make it better? And how do we support innovation? And providers actually reflecting on their practice is an important piece. So there was like a 4-step that we've worked over this last 5 years, 6 years. We have core content to nursing that applies across many domains. And so we have a nursing content standards practice work group. And in addition to that, an allied health one and a physician one that helps us make decisions. Rob might speak more to the physician groups. But then we also had to recognize you have specialty content, and we have a lot of groups, we call them area councils, that work with us in the Connect Care project to take that core and then figure out how you add into that over and above and maybe tailor it to the specific needs of different specialties. We first met, our nursing content practice standard work group met in first meeting was April 17th, 2018, and we still meet today. We kind of postpone during launches every 6 months. We take a 6-week hiatus, but for the most part, we're every Tuesday morning. We have 50 nurses or so across multiple specialties and professions. And we have partners in our Connect Care project, eSafety, Human Factors, professional associations, professional practice. They all come and contribute to how are we building this out in our electronic record. And I think our success has been strong nursing leadership. The Associate Chief Nursing Officer in AHS and myself, we chair this committee. And so it's key. You've probably heard through lots of your presentations or your classes, leadership is very important when you're looking at a project like ours. The role, I won't get too much into this. We look at setting standards, we're acting for the change, and we're advocacies for change. There's lots of change in this. We look at issues and risk. We do prioritization of what we think is important to work on. Haven't done a great job on the systems benefit realization because our We've fallen down a bit on measures, but I'll talk a bit about that in the back end. And we've always made sure that we're adhering to practice. So CARNA, setting the standards for nursing in AHS, we look to that group a lot for discussion. This was some Connect Care guiding principles: put patients and families first, move fast, make decisions, don't ever go back. Unless you really have to, but for the most part, stay on track, avoid variation, lead with purpose, and transform with intent. So really good principles that we would, if we ran into difficulties, we'd pull the principles up in meetings. Maturing in the approaches, as I mentioned, that is where we're at. You got to really be humble, and you got to accept the criticism that your end users are giving us. We're looking to strategic direction setting next around quality, safety, and initiatives like choosing wisely that improves nursing care or assists with improving outcomes for patients. We want to look at innovation. We're always looking at different decision supports, but not looking at the cognitive, or wanting to prevent the cognitive overload you see. We are empowering nurses with data. Well, that is something we need to work on. We tried, but we haven't done very well on that. I'll talk a bit about that and the outcomes measurement strategies. So at the beginning of this, it was like moving a ball, up a hill, or throwing a noodle up a hill, but a lot of work over the last 5 years. Just quickly then, we break our workflow in nursing down to admission, daily cares, and discharge processes. That's kind of how you set your nursing tone. And we've got admission screenings where we've standardized. I mean, we used to have many falls risk screenings, for example, but we got down to 4 in the, when we launched. We look at nutrition and pressure ulcers and suicide. And for the most part, we've done a great job in AHS standardizing these screening tools. We have a discharge screening process, and also we look at discharge planning. We did a lot of work during COVID-19 identification and symptom monitoring that we're kind of scaling back, but we were nimble as a project to be able to stand up and meet the needs in our electronic health record. Rob will lead a lot of that work. He'll know a lot about that pieces. We standardized our physical assessment, so our systems assessment. And we did an approach to try and reduce burden that's called within defined limits, where we standardized documentation definitions for each system. And we looked at an evidence-informed approach to that. So for example, we standardized neurological, what to look for. And if it's out of that, then you gotta document and do some documentation. So we followed a vendor methodology here, but for the most part, I think it's assisted in, reducing some burden. Managing our care, we standardized our ins and outs, our vital signs, our daily cares. We incorporated decision supports around falls and nutrition and communication. We have evidence-informed care plans that we actually didn't launch with, so some work there. But we also standardized our handover, which was iDraw, and some other things like early warning systems for the deteriorating patient, both adult, pediatric. We put that in the system, and we have a predictive model on sepsis and ED. Patient teaching and discharge, we align to our AHS collaborative care program. There's a bit of burden here, and it's something we need to relook at, but we did take a stab at standardizing our discharge through checklists and patient teaching. So have a really good start, but lots of optimization. Other aspects we looked at: nurse protocols and initiated protocols. So what they could do within their scope. I talked a bit about the predictive analytics, and there's more that we can do around this. And then strategic quality initiatives we hope to look at in the future is the choosing wisely, 9 things nurses should question. There is a role for nursing and all care providers in EPIC to improve the patient outcomes through some of our, just by virtue of launching this and launching a patient portal, we've really moved the mark in how patients interact in their healthcare. We have about 250,000 people, Albertans, on the patient portal today, but there's a great opportunity to keep advancing that. And from a nursing perspective is to keep providing standardized patient teaching materials that could be moved to the portal for patients, and participating in after visit summaries and documentation around that. So some of the things that not only nurses, but the whole team can do to improve our patient outcomes. Successes, I think I kind of talked through this, evidence-informed best practice into documentation. We did reduce the burden, we think, but if we know we have a lot of concerns coming from our nurses, because we just did an ARCH collaborative survey. So now I'm kind of, we may not have reduced, but maybe we reorganized it. So we got to go back and take a look at it. We did really try to avoid the duplication, less narrative and more data driven, and reinforced patient safety, standardized clinical information wherever we could. So upon reflection, it takes a while to really get this right in an electronic health record, and even harder to do it while you're in full implementation for 5 years. We just did an end user satisfaction with the ARCH collaborative, and there's a lot to work on there for sure from our users. We need to build more nursing outcome measures into this and really provide good data so they can evaluate their practice. There's research opportunities, but we didn't really determine those up to now. I think it's a strategy for us going forward, and there's opportunities to align to national terminologies into the future. Just a bit on our ARCH collaborative survey. We had our nurse satisfaction is lower than the collaborative. However, there's many reasons that contributed this, but it's a really good signal for us to say, we heard you and we need to look at this. And we have some areas for improvement around flow sheet documentation and nursing communication orders. And I think, overall, we want to celebrate. AHS did a great job in getting this electronic system started, launched. We have some great starts on the standardization, but we don't ever forget that we need to make it better. And so that would have been my last slide. I went fast because I know I wanted to let Rob go and then have some time for questions at the end. So I'll stop sharing. Probably
Thanks.
turn it over to Rob.
Yeah, over to you, Rob.
Thanks. I trust that you can still hear me, and I'm sharing my screen now. I hope that that's coming through.
Yes, all good, Rob. Thanks.
Okay, thanks. So following up on that great context and background, and putting Connect Care's efforts with upfront standardization, terminologies, consistent ways of categorizing things, really doing that at a provincial level, which is a great opportunity for bringing consistency to the way in which care is practiced and documented, and then decision supports are provided to improve practice. All of those were our ambitions, and I think it falls to me to not only dig deeper into the details, but also to illustrate an area where we've really been struggling post-launch, and how we've been licking some wounds and trying to reconsider how more consistently structured tools might help us bring some order to, I'll say it very frankly, some unanticipated mess that emerged in our clinical documentation. And in this, we're like so many others in this new digitally enabled healthcare space, where there's been a lot of challenges with improving the signal to noise ratio as opposed to degrading it. So the objectives for my part of the presentation are to work through what you might consider to be a case study or a use case in how we've been iteratively trying to improve the quality of clinical documentation and its clinical utility by focusing on the things that are used to build it at the level of right down to terminology, but then also through standards in the way in which documentation is structured and norms about what we expect or don't expect documentation to contain, and then processes around moving from documentation as an individual to documentation as a shared activity. These are all very, very tough, not only process challenges, but in many respects, cultural challenges. And so, as Debbie and I have learned painfully, you need to take the long view and measure improvement not over weeks or months, but over years. So hopefully this case study will illustrate how a post-launch effort at rebuilding standardized building blocks for documentation can improve documentation quality, and then how a new way of working with, interacting with, and experiencing documentation might encourage end users to actually adopt those building blocks. So I'll say a little bit about the context, which is a universal problem of note bloat in digital health records, talk about how we qualified and quantified the extent of our note bloat challenge in the Connect Care initiative, and then built around that a documentation quality improvement program and what its key elements were before getting down to some of the more technical things that we did through building block optimization, and then the creation of an alternate user experience that might make the use of structured documentation more attractive to end users. And hopefully that will generate some other questions or suggestions in our question period. So I'm sure all of you are very familiar with how extensively the public media, as well as the informatics and the scientific literature, has lamented the emergence of note bloat as a common affliction in digital health record initiatives like Connect Care. What one ends up with, what this colloquially is referring to, is clinical documentation that for clinicians that need information quickly, it's documentation that they experience as being difficult and time-consuming to read, cluttered by inconsistent or inappropriate use of text, tables, lists, fonts, styles, all the cool things that people can get very excited about being able to insert into their documentation with great ease of various smart things, but with a result that comes across as being less than smart. Note bloat also, and most importantly, causes cognitive dissonance. It obscures what is clinically important and decreases the situational awareness of decision makers. And therefore, note bloat is actually important to recognize as a patient safety threat. And it was that led us to prioritize it as our biggest post-launch challenge and priority for working on within our clinical documentation oversight structures. Note bloat, as we now enter into a period where there's more and more effective use of artificial intelligence and verbal models for working with text, note bloat generates content in a record that is actually surprisingly hard for AI-enhanced tools to work with. It's hard to sense what the real priorities are because there's so much junk in there that isn't clinically important. And what is important isn't set apart in a way that is actually easy for language models to deal with. And at a much simpler level, if you try and find in a large medical record that's grown over time, and these records get to be truly massive, if you then try and use Google-like intelligent searching capabilities, if you've got note bloat afflicting your documentation base, then the search engines really struggle, and you tend to get long, misordered, and imprecise results when you search for something. And if you're trying to interact with external systems through the sharing of information, and to have that sharing be semantically sensitive and responsive so that the right things go to the right places, if you're just dealing with disorganized blobs that are highly repetitive and have little structure within them, then sharing with other systems becomes a challenge as well. We were starting to experience all of those things and recognize that at a cultural, at a fundamental level, at a human level, we were witnessing a struggle with a paradigm change. Even though many of our users hadn't actually worked with paper and have terrible handwriting and really are not well equipped to deal in a paper world, society hadn't really caught up, and they were using paper-based cognitive norms and applying them in a digitally enabled environment. So rather than using documentation as a data review, rather than using documentation as a data analysis and an interpretive communication tool, it's being used as a clerking and a data reproduction and review tool, much like in the paper days. Another challenge is that the great promise and the opportunity of clinical information systems is that we wouldn't be able to move from an emphasis on the what, the content, the data, the lab results, the x-rays, that's all there for anyone to see, and you can access it instantly and with great ease. So the opportunity is then created for documentation to not reproduce that, but rather to indicate what meaning it has. And so to be interpretively rich. And that's something that we saw we may even be going in the opposite direction, which was a real disappointment. And then there's a bit of a generation gap. We found paradoxically that our younger clinicians seem to be very information facile, but not necessarily information literate. They really struggled with a sense of what's important to document and recognizing change that is clinically meaningful. And so that actually paradoxically created an opportunity for our more seasoned clinicians to emphasize that clinical documentation is actually good clinicianship. It's not a chore. It's not something that you just have to do and waste time in your day. It directly shapes the way in which you think about the patient and about clinical reasoning more broadly. And so we've been starting to have some really good interactions between those that are clinically wise and those who are infophilic. So let's go from the theoretical and my rant on a soapbox to some of the details. I mean, what proof do we have that we were actually getting a documentation quality problem on the back of this great and expensive and what we felt was very successful initiative? So let's look at some of the contributing causes and how we then recognize those and build a program for improvement around that. So we kind of knew by instinct and focus group equivalent discussions in our various oversight groups that we had at least three things that were driving note bloat in our context. One is mistuned tokens. Now our vendor Epic calls those their smart stuff. They're smart links, they're smart phrases, they're smart lists, they're smart forms, they're smart this, they're smart that. Various text automation tools that allow you to generate a piece of documentation by pulling information from various places in a pretty seamless way. But that great rich with thousands and thousands of these tokens, if they're not used the right way, and if you adopt them straight from the vendor without normalizing them and rationalizing them for your clinical care context, for us, the province of Alberta, you can get an ungodly mess. We really were suffering from misuse of copy paste and copy forward. It's something that is almost a pressure that is impossible to resist. It's just so easy to copy something, throw it in, and be done with your note and not think very much about what you've done. And we saw particularly with trainees that there was a lot of that happening. And then there's misplaced documentation, failure to document patient-level data in the right context, as opposed to patient-level, content-level, note level. And then we have what's called episode level and continuum of care level. And there just didn't seem to be a recognition amongst our end users that these different domains of documentation exist. Again, people who are information philic aren't necessarily information literate. And so we were exposing some fundamental problems in health information literacy in our user population. So we decided this was not a problem that was going to go away quickly. We researched the experience of others, and the overwhelming message from centers that had made progress in this area before us is that you need a systematic approach and you need the long view. And so we made an effort to figure out what that approach would be for us, to tightly couple that with oversight that would plug into the structures that Debbie highlighted, that before we went anywhere near any technology or tools, we needed to really step back and figure out what the norms are for the digital age that we wanted to be able to follow and promote in our context. And norms really are at a very high level, but then can inform principles, style guides, references, best practice examples, and so on. We wanted to figure out how we would monitor what people are doing through audit, provide useful feedback so they know what they're doing by reference to the norms, and then allow people to see how any quality improvement interventions trend over time. So we needed a compliance structure and a feedback structure with an improvement drive to it. Only with all of those things in place would we then spend the time to go back, look at the documentation tools that we had launched with, and rebuild and redesign, which was a huge effort but we've made a lot of progress. Of course, these things don't happen just by themselves. Training is much more than providing education. It's providing the cultural and imperatives and incentives and mentoring and all kinds of incentives for moving to a different way of documenting. And then we wanted to make sure that we had solid change management as well as evaluation frameworks. So we got the first couple of things underway with pretty much what Debbie talked about. What I'm highlighting is that we developed working groups that then fit into those governance structures, but were accountable to them, so that there would be, within Connect Care province-wide, very high visibility for this work. It was through a 6-month priority setting process post our first couple of launches. Every group had to identify what its top priority was, and we made the improvement of summative documentation one of our top priorities provincially. We then needed to work very hard to come up with those norms that I talked about, and that work was not trivial. It was built by consensus, but as I'll share with you in the final slide, this is not something we're keeping to ourselves. We've shared with colleagues across the country and have also benefited from the sharing that they've given to us and other EPIC clients in Canada and elsewhere in the world. Were very generous in sharing how they had built principles, practices, norms, compacts, and so on in this space. We definitely stood on the shoulders of giants, but then came up with something that was published in paper, digital, lots of different formats, and became our kind of conceptual foundation for moving forward with development. I'll move forward a little bit more quickly. One of the things that was really gratifying is in working with our vendor, Epic Systems, we found that this is a priority for them as well. It's generally a priority throughout the medical record industry, and a very rich set of data tools had already been developed for us to take advantage of. So we internalized these within Alberta Health Services, and this allowed us to look at the individual level, to identify actual clinicians who would have, we could define the flags, the thresholds for things like copy-paste or overuse or underuse of the various smart things, doing unstructured documentation where we really would like to see more structured documentation. So we were able to set up these things and then generate reports at division, department, facility levels, so we could see which areas were really struggling. We could just hover over our flag indicators that we created to see what kinds of problems there were. We also were able to get summaries at various levels, so that we created analytics around note composition, note length or quantity, as well as quality. In what context were we seeing different attributes, and how did those compare to other large organizations like ourselves at similar stages of their journey? We could then find illustrative examples of the kind of red areas where things really seemed not to be going very well, and pull those up, and here's an anonymized one of them. We then can look at exactly what the problem is. So I'll just illustrate some of the things we were then able to discover through the qualitative analysis that was working with a population of documentation objects that had been identified through those reporting tools that I just illustrated. So here is an actual progress note, if you can believe it, that extends to 14 pages in length. And as we analyzed that, we found that despite our provincial standards for things as rudimentary as how a date should be specified in ISO format, there's a lot of variation in leading digits in 4 versus 2 years. And this may seem trivial, but if you are a clinician unconsciously and you're seeing dates in many different formats, that contributes to cognitive burden and to cognitive dissonance ultimately. So something as simple as that just had to be fixed in the building blocks that our users were using to create these things. So that's what EPIC calls smart links and smart phrases. We needed to go through them, pick the ones that were going to be adopted for Alberta as a standard, make sure they adhered to our inclusiveness guidelines, the way in which we wanted to represent and talk about things like gender, how we deal with ethnicity, how we deal with dates, how we deal with weights, all of the things that Debbie talked about that were in that clinical content repository. You don't get that from EPIC. Sadly, that's work you have to do yourself, and we realized we had a lot of it to do. Other things as rudimentary as what font sizes are being used, when are tables being used as opposed to prose, when are lists being used, what does underline mean, what does bold mean? And as you look through this 14-page document, it's a dog's breakfast. These different formatting cues were used for entirely different purposes in different places. That too contributes to cognitive dissonance. We found that our norms, which had now been developed, were unequivocally not being adhered to. There was a lot of duplication. There wasn't documentation by exception or within defined limits, as Debbie was describing. So we'd somehow missed the mark in what was emerging out there in our wild. We found that many things were pulling in data that was not formatted in a way that would facilitate quick visual skimming for that type of information. We also found that, as I mentioned before, all of this contributed by people pulling in details that weren't really necessary to the purpose of the note, things that are ridiculous. A progress note is about what's changed today by comparison to yesterday. And if it takes you 14 pages to describe that, something is fundamentally wrong. So after that work, which took us a full year of thinking, looking at what was going on, trying to map it to the experience of others, we then went into a building block optimization phase where we looked at the tools that users were using and undertook an overhaul of those and the creation of AHS badge of honor and a way to recognize the things that we approve and promote as opposed to the things that we would discourage. We're now at the stage where we feel strongly about this, that we are doing spring cleaning and removing things that we don't think are appropriate from the toolkit of smart stuff that users have access to. So that then led to some things fairly simple, such as if you're listing active problems, we would list them always in a standardized way that would highlight the clinically meaningful categories of a principal, active, passive, chronic problems, things like that. We made sure that anytime medications were shown, that there was always a standardized format that mapped to what clinicians are used to reading, rather than complex tables that were more appropriate for stickers to go on prescription bottles that or dispensed medications that patients might receive. We also looked at all of the smart tools, looked at the ones that were being used most frequently, because all of this is audited. We can see exactly which building blocks are used by who, where, when, and how often. And we focused our work on the heavy hitters. We then expressed those norms through the creation of preferred templates for progress notes, for histories and physicals, for consults, for discharge, for operative notes, and so on. And we made them all look pretty much the same so that if you've seen one, you can quickly skim and find the relevant material. We went through an initiative with external stakeholders, the consumers of documentation. So the family docs, the primary care networks, our College of Physicians and Surgeons, our allied health organizations. They were, if not represented in our governance groups, we went out and did external consultations. And we heard very strongly from them that they hated our documentation. They wanted the clinical bottom line up top and the less important details at the bottom, which was exactly the opposite of what we were doing. So we came up with structures that reflected what the readers of the documentation said they most needed for meaning. And we came up with very readable, prose-like templates that would have collapsible sections so that you would have that clinical bottom line in your face, clearly directive, emphasizing assessments and plans, but then be able to drill down to details as necessary. We did implement all of our standards for the ways in which dates, gender, everything, names, provider names, do we use honorifics, do we not? We standardized all of that and fixed all of the building blocks to make it consistent. We followed some guidelines that have been developed for how you communicate effectively when asking a clinical question of someone and seeking an answer in return. And that structure, the implied structure, is to have the question at the top, a kind of roadmap or an outline of what the big issues are, a succinct integrative statement, and then action-oriented references to those key problems or health issues, with an answer as close to the top as possible and supporting details towards the bottom. We wanted to make sure that we weren't telling people they couldn't use their much adored Dragon Naturally Speaking, their e-dictation systems, but we did make sure that if you were dictating, it went into places that we then tagged and pulled in as structured data so it could be reused elsewhere. These colors illustrate what is generated automatically, what's facilitated through a mix of dictation and semantic recognition, and then things that come out of what we call problem-oriented charting and things that were just purely dictated. You can see the dictation burden is much smaller than what was happening before. Okay, so if we've done all of this, how can we make these new documentation tools more attractive to users? Well, from focus groups and tickets and so on, one of the things that users were just shouting out at us is, there's too many different ways of doing things. I spend all of my time poking around in the chart, going from tab to tab, place to place, losing my place, and it's very inefficient. Allow me, if I am documenting, if I'm creating a consult note, I want to interact with that consult note and nothing else. Bring the chart to me, do not make me go to the chart and its parts. And so we developed what we called interactive charting, that your charting as you did it would interact with you. And if there was something that looked a bit off, you would simply click on it, edit the data right in place through pop-ups or fill-ins to more powerfully incentivize structured data collection where that makes sense and standardized. We had guiding principles. I won't belabor them. The slides will be available to you. And then we needed to find a way to move that into practice. And so we used all that the technology could do to create for the key documentation objects that everyone needed, a standard for the entire province that was our generic standard. And then we built into it the smarts that if it recognized you were a particular specialty or working in a particular clinical context, it could automatically, without asking you to do anything, swap in a variant of that standard that would serve your purpose, but not abandon the overall structure that had been standardized for the province or any of the building blocks that had been standardized for the province. So that's what we mean by conditional content while working with standardized layouts. And the interactive part is that we adopted a standard that anytime you saw dark blue text, which conveniently would go out to external information systems, consuming systems, and not really affect their PDFs or anything, the user could click on those in order to interact with the document to get it to do what they want. And here's just an illustration of that. You can see some text that is being generated as part of, in this case, the hospital course that starts to fill in automatically. And the user just clicks on that to change the structured data elements. And as soon as they click on OK, then the sentence changes, but it's still a familiar sentence that is easy to read. And there's many variants of that. At the same time, we started to really push the documentation tools that in wiki-like fashion were shared, so that if you started to work with them, the hospital course, patient coordination note, problem overviews, assessment and plans, subjective objective notes, we made all of those shared so that if you've got a team, everyone can work on them simultaneously, and that decreased the total informational burden from any individual. And we found once people had made the jump into this shared and interactive space, they would never go back. Getting a discharge summary became a 5-minute activity as opposed to a procrastination-inducing half-hour, 1 hour, or 2-hour activity. And then we made an effort to one of the real challenges with Epic is there's tons of smart stuff, but you have to be way beyond smart in order to remember all of the mnemonics that are necessary to access that stuff or to look it up in an efficient way. So we created standardized sidebar that would be in the clinician's face for every single chart, and we made that very focused on their needs and what they wanted. And again, expanded this interactive charting so that for standardized documentation objects, you would simply click for what you want and not have to remember what the code is or the mnemonic in order to look that up and use it from a blank screen. So if you clicked on any of these links, we'd take you to the right documentation editor, preload it with the right template, recognize your specialty, make the adjustments, and then you're up and going. And then we did things like really try and make these tools prominent in various places throughout the user interface to make quick buttons and ways of accessing them very quickly. We also sought ways to support what we call build your own journey, so that you could start with something that's very, very succinct, and anything that is in light yellow, if you ignore it, it disappears. If you interact with it, it builds that little bit of your documentation in a just-in-time making choices as you go, so that there's the flexibility, because we got some initial pushback from our template development that it didn't provide as much flexibility as our users wanted. So we needed to get them using the same overall structure, but provide them with points of departure within that structure where they had more freedom to do what they felt they needed to in the moment. So there you go. We're now at the stage that we've completed all of the overhaul. We've been working with different types of training strategies, and I'll just conclude. I've taken more time than I wanted. We're now at the stage where all of these new tools are in production, and we're going through the very, it's sobering how time consuming it is. It's so much harder to unlearn something than to learn it, but that's just the way it was. With our new launches, we're finding that the uptake of these tools is happening at about the time of launch, and good habits are being developed. With those who launched in the first 1, 2, 3 waves, we're trying to go back to them and try and unlearn their current documentation habits to get to more efficient and effective ones. And that is proving to be a lot of work, while we're still having to allocate resources to getting the final waves launched in the province of Alberta. I'll leave this slide up for a little bit, but for those of you who would like to actually look at the norms and see if there's anything of value for you in there in the spirit of documentation standards and expectations, that would be the URL to use. Our manual, which has got a lot of the information about things which I've talked about, is there. And then we have a blogging series called Building a Better Health Record, the title of this presentation, and you can access those blog postings by using that particular URL. And with that, I'll conclude. And you do have access to these slides as well.